loop.
That's a nice line. As a what?
Lifestyle. Loop. Tell me about it.
Everything is loop basically, so you don't have to go anywhere to get all your business done. From this one place, you can get transactions between your bank and your mobile wallet. You can pay your utility bills. You can sort out standing orders. You can make sure that all your payments are set up on time, ready to go. If you're in business, you can pay your merchants. You can pay your suppliers. You can advertise on the app to let people know what's available. I mean, it's fantastic stuff. All you have to do is download it. Download it today on your Google Play Store or Apple App Store. Download, and get into this lifestyle of not having to go so many places to get certain things done. And guess what? If you download that today and give us evidence of that, Edward, during the Spice Drive today, we'll award somebody 5,000 bob.
Evo.
Yes. Download. Get into the loop lifestyle. Why wait when you can loop it?
Exactly. So, Dr. Lishenga.
Interesting.
It costs this much for a cesarean section at, let's say, Mama Lucy. Costs this much plus X at KNH. It costs this much times Y at a private facility. Why?
Well, George brought up a very interesting point. I will start from the point where he was saying NHIF was not giving money to public level 2 and level 3 facilities, which I will tell you, it's just a governance issue. And, we were just talking about maybe, let's say, how Irungu Kangata has done things differently in Muranga. And it's very simple. Do you know that all the counties get capitated, that outpatient money, but most counties receive that money into a single bank account that is attached to the, say, county referral hospital or the sub-county hospital. So money for dispensary X never reaches dispensary X. It goes to a county hospital and it is spent from a central. In fact, before FIF, that money could even be spent for roads, So what are reasonable governors doing? Simply, very simple things, my brother. Like what, you were talking about Moranga. What they have done is open bank accounts for every single dispensary and give those bank accounts to NHIF. You know how, SHA now, you know how NHIF usually works is once they say this area has 100,000 people who are beneficiaries. They simply do a math and they pay you the money for providing care for those ones into the account that you have given them.
Right.
So if you gave them accounts for 50 dispensaries, say in Kakamega or Makueni, whatever it is, they will pay money according to the number of beneficiaries attached to those dispensaries, and our dispensaries will be funded.
Right.
Now, that is to save my colleagues in the private sector, just to say, it is not that counties or public sector have been not getting money and private. It is because of policy at government level in terms of where the money goes. Now, on the question of, say cost of care, one of the things is that we keep forgetting is that the cost of a cesarean section is the same everywhere. It is the same at Mama Lucy and it's the same at a private hospital. The only difference is that at Mama Lucy, the cost of HR is absorbed. So you don't see it on your patient bill anywhere. So the cost of HR is absorbed, the cost of power is absorbed, the cost of rent, all these things are absorbed by the national government or the county government, whoever it is. They don't appear on the bill. But when you are in private sector, all these things are itemized somehow within your medical bill. And that is why the cesarean section that my colleague is talking about, 115,000, actually I'm surprised. That's rather expensive. We have private hospitals that are giving cesarean sections for 30K. If you look at the SHA benefits that is going to be rolled out, cesarean section is 30,000. That's the reimbursement. So why? Well, some private hospitals and even government hospitals co-charge. They charge a little more on what is reimbursed. And private sectors will have a slightly higher bill because of these other costs that cannot be absorbed by the taxpayer. So the cesarean section costs the same thing. It's only that on this other side, HR is taken care of, power is taken care of, and it doesn't appear on your bill. You asked a very important question before we went on the break as to whether we needed these reforms or we can just stop this bus and get out. They are good things. about these reforms. I do not want to throw the baby out with the bathwater. And you also said we shouldn't just complain. And we don't want to consistently complain. Let me tell you a few good things. One, nobody in the sector is against the Emergency, Chronic and Critical Illnesses Fund. We want it. I mean, this has been one cost that has been ballooning and is predicted to keep ballooning as our population ages.
Yes.
So this is one of the very, very nice things that came through. Another thing that is, I think, quite interesting is around the Digital Health Act, where now we are finally going to bring all this data that we are collecting in the health service. We don't exist in silos. You know, your hospital doesn't have its own pool of information. If the digital superhighway works, the court cases notwithstanding, if it works, then for once in the country, we will be able to know how many diabetes cases, how many malaria cases, how many products, all these things will become visible. That is a great thing. The primary healthcare fund, as envisioned, is fantastic because now there seems to be a deliberate effort to fund healthcare at the level 2s, level 3 facilities, which have been ignored for a long time. The criticism we are offering is that all this thing boils down to what George was saying, and I wish he had stayed on that line. This thing boils down to government bad behavior. You know, today, if, you know, let's say here at Standard Group, if, you know, as a private sector employer now, if I don't remit my NHIF for my employees by 9th of every month, where will I go? In fact, let me make it even interesting. The same SHA and NHIF, do you know they refuse to pay us for not showing, when we invoice them, for not showing our NHIF compliance certificate? So we find that extremely ironical because it is them who haven't paid us for us to be able to do these things. But then they also turn around and say without a compliance. But government agencies, SAGAs, what we call semi-autonomous government agencies, you know, these roads, whatever, all these universities, you know, county governments, they owe colossal amounts of money to the fund. And that is what worries me about the 2.75%. This 2.75% will be deducted from every single employee's pay slip. And historically, you know, they say what the best predictor of future behavior is what? Past behavior. So it's going to be deducted and it will not arrive. That is just the first part. We don't think the money will arrive. The second thing I have an issue with, and which we have criticized, what is this means testing? You know, I was watching the university funding model. They are complaining about means testing. It's the same business we have brought into SHA. We are now saying the informal sector is your contributions are going to be determined by a means test. I don't know if you guys have logged into that website, but if you go in on the SHA website, and now also that's a problem. You know, Guka or Shosho or
it's not going to get on the website.
It's not going to get on the website. But if you do manage to navigate, you will find that your premium changes immediately. You say you have a microwave, and ukiweka tu hapo refrigerator, you are now a very wealthy person. Now, of course, we have criticized it, saying that using means testing as the means to determine how much the informal sector will generate will result in people, one, cutting shortcuts and lying.
People will under-declare.
Yeah, you know, we know there are people in the informal sector who make a lot more than people who are on payroll. They are going to simply under-declare. Because how am I going to say I have 2 cars or I have a motorcycle? Imagine our brothers who are in the border sector. Once you put there that I have a border, your premium shoots up. So there is an inbuilt incentive for people not to contribute. And these are the criticisms we have made. We are saying, number one, the biggest employer in Kenya is government. If government does not have physical discipline to remit funds, there is no way you can simply make the sector work by changing the law. People have to behave properly. You know, the parastatals that owe NHIF money, you know, the SAGAs, etc., let them remit money. Because if they can't remit NHIF money, they will not remit SHA money. You get what I'm saying? So the major issue is around how do we raise the money? Means testing is wrong. My colleagues in the sector have said we should have gone for a general tax. You know, we should have gone for a general tax. Every time I pay, if I'm wealthy, I'm going to buy a pair of shoes, maybe, I don't know, 7,000, 10,000. I pay a little more than the person who can afford a pair of slippers. But if the one who's affording a pair of slippers pays 1 bob, and I pay 1,000 shillings, we are both contributing in that way. We will have captured everyone. We have said you should have gone for general taxation, created a law to ring fence the funds created in this manner, and then used those funds to fund healthcare. But telling me to go on a website and type and declare myself, this is not going to work. And we are going to burden the few employees who are in the private sector with the funding healthcare for all Kenyans. And what the CS didn't say yesterday, really, the other day, is what they are really calculating is that the 2.75% is also going to fund primary health care. Is also going to fund the critical fund. That is their math. Because once the money hits the SHA bank accounts, you and I will not know how they are manipulating that money, where it is moving. And yet the law is clear. It is Parliament that needs to appropriate money for primary health care.
Primary health care and the critical emergency care.
And if you ask me, CS Treasury, this thing actually falls right on his doorstep. If he does not open the coffers for emergency critical chronic fund and primary health care,
it's going to be a crisis.
There will be a major crisis.
So come next month, because even yesterday, the PS for medical services, Harry Kimtai, said from next month, we have started the transition. Come next month, from your understanding, George, what will happen to this person in Kimana who goes to Kimana dispensary? The law says that this person goes to Kimana dispensary, gets treated, goes home without paying a dime.
Yes, let me start from there. Before that, allow me say, Dr. Lishenga is a good man. And let me advocate at least and profile him a bit. That even what we are seeing in Maranga, he has a lot of contribution there. And that is why I want everyone to know that he has contributed a lot.
Give his flowers.
Yes, it is his flowers. Okay. So, having said that, I'll mention on what he has talked about the issue we are experiencing in terms of deduction happening to the employees not remitted, ending up to deny that person a service when they need it. We proposed, even when this issue was there, that the money should be deducted at source, because there is a central coffers which disseminate that money. But why can't we do it at the central place, so that then we don't have issues where you are claiming county has not remitted and yet you gave them the money? So, but that was not taken. Now, when you look at it now, what you are talking about, what is going to happen now that we are rolling out? I presume, and I feel that probably nothing, because the sensitization has not happened. A majority of Kenyans do not know what is going to happen. And it will have probably changed if the government took the initiative of doing their part of what they have called the mean testing. It should have happened so that before they say how many have enrolled, they will say, we already have this number of indigents that we're going to pay. What the government is supposed to be doing, it has not done it. But it is asking those others who are supposed to be doing to do it. When they tell everyone that you must pay the 2.7%, they are supposed, the appropriation of NHF for it to roll out the primary health care was around 50 billion. They only got 4 billion.
4.1 billion.
Yes. I normally don't say the point because
so the point one is 100 million.
Yes. So when you look at the other side, is that in the critical care and emergency, the approximation was 100 billion. So what are they getting in return? So that's what we are saying. When you look at that, the action is not really in line with what they are telling us.
So the focus here is more on collecting money.
The status quo is more of what we see than the services that they are talking about.
Okay. What will you have us do, George? So
what we have to do is that we have to be realistic. And the government, if they want to enhance services, they must be listening, and they must be able to ensure that if we want something to change, let's do it in a manner that it is realistic. promising things that you are not going to do is bad. But again, if government has a role to play, let it play its part first before you start asking individual Kenyans to do it. Because then that's how you win trust and the people feel that they are part of what you are doing. If you tell us that indeed what we are going to get is going to be, because why I say that is status quo is that you have already said, if I'm not enrolled, I'll not get services. And I will tell you, in the next 1-2 years to come, we will still have a percentage of not less than 24% of Kenyan, because the transition will only happen for those who have been under NHF. Unless the right measures is put in place, then so that there is a motivation for those who have never been in any form of a cover, medical cover, to be enrolled, then nothing will change. Because in any case, if today you have told me that I don't fall under the category of indigent where the government will pay for me, and I have a child who have been chased away from school, who is I'm supposed to pay the school fee, and you're telling me to pay probably 500 shillings, or even a child who is sick, and at that time the next facility next to me is either pharmacy that I have to buy some paracetamol, and where I come from, anti-malarial, like in Nyanza. What will I choose to go for? I'm actually struggling to put a meal on the table, and you're telling me to pay 500 per month.
And you've already declared me an indigent.
Yes. So what I'm saying is that the government is going to experience a lot of difficulties, and the best way it will have gone, I think what Dr. Lishenga is saying, will have gone to a way of a tax-based, so that we identify on a line of this is how we want to get this money, and it be done. Now, let me bring to this aspect, like I was in Botswana the other day. Botswana have no like a national insurance cover, but they have a kitty, they have allocated money. Every citizen can access services at any level, provided you are a citizen. You only introduce your card, and there is no enrollment. Yes, people talk about their number is low, but indeed,
the principle,
the fact is that they have a money that have guaranteed services at every level for every Botswana without paying. Now, when you go to where we are talking about, I think we have been talking about Malaysia and Singapore. What did they do? They came up with a similar way like NHF actually, but they grew a kitty to a manner that currently, like Singapore, they have a fund that can run 5 years. If today they stop paying, it will run for 5 years. So for us, we have bad manners, as he has said, that even the little that we have contributed, it ends up in individual pockets. And people lose life day in, day out. It's a life and death situation.
Yes. As we conclude in about a minute, Dr. Lishenga, rural private hospitals play a critical role in the provision of healthcare services. Come next month, those that have been coming to your facilities and, using NHIF, what's going to happen?
So we will not turn away any Kenyan. We will offer care. The question is, under what terms will we offer care? I want my former classmate, the CS, to succeed. I want my colleague Abdi Mohammed to succeed. But I will tell you without any doubt that it is Mbadi who will fail them. And in the absence of the CS Treasury, and I'm basically saying whoever holds the keys to the purse, in the absence of them opening those purses and putting money in the sector and showing, as I began by saying, put your money where your mouth is, out-of-pocket expenditure in this country is going to skyrocket from 1st of October.
Oh, my God.
This is what I can tell you. It should be informative to you that 1.2 million Kenyans only or so have enrolled. And if enrollment is a criteria for accessing care, what will I do with the 50 million who haven't?
And they come to your facility.
And they come to my facility. And what will I do with the fact that my drug store is empty and you are now waiting for share money to pay NHIF debts.
It's okay. Picture painted. It's okay.
Got it.
Just go. Dr. Brian Lishenga is the chairman of the Rural Private Hospitals Association of Kenya. George Kibore is the general secretary, Kenya Union of Clinical Officers. Thank you for tuning in to the biggest conversation today. Have yourselves a lovely day. See you tomorrow. It's 10 a.m.